I would like to introduce our guest. It's my privilege to introduce our lecturer, Professor Max Aebi. Max Aebi is Swiss-Canadian spine surgeon. He was born in 1948 in Switzerland. He completed his medical school at the University of Bern, Switzerland in 1974. He did his residency in general surgery and orthopedic surgery in University of Basel, Regional Medical Center, Kantonsspital Aarau in Switzerland, respectively between 1975 and 1982. Between 1978 and 1983, he had training in microsurgery department in University of Basel. In 1984, he did his fellowship in Great Britain, USA, and Canada. Currently, he is Professor Emeritus, University of Bern, Adjunct Professor, Department of Surgery Faculty of Medicine, McGill University, Montreal, Quebec, Canada, Honorary Professor, Armed Medical School, Rawalpindi, Pakistan, Chief of Staff, Orthopedic Department, Hirslanden Salem Hospital, Bern, Switzerland, and guest professor of several universities, more than 15. He is also a clinician. He's practiced or focused on reconstructive spine surgery, musculoskeletal tumor surgery, trauma, post-traumatic deformities. He is contributor and patent holder in modern spinal implant technology. He performed about 6,000 procedures evenly distributed in general orthopedic surgery and traumatology. 7,000 procedures were performed in spinal surgery. He is also noted for humanitarian work in areas such as Pakistan and Armenia. He is also a leader. Aebi is founder and former chief of the University of Bern Spine Unit. That is the first academic spine unit in Switzerland. He is chair of orthopedic surgery at McGill University in Montreal and orthopedic surgery in chief of the McGill University Health Center. He is the co-founder of the orthopedic department at the Hirslanden Salem Hospital in Bern, and also foundation including Eurospine, Media, EO Spine. He is the founder and editor-in-chief of the European Spine Journal, one of the highest-rated scientific journal in musculoskeletal medicine in Europe, and also founder of the MEMDAC platform for registries. He is currently coordinating editor of Edge Learning, an online spine surgery education program. At last count, he is a researcher and teacher. Professor Aebi has authored or co-authored over 400 articles, reviews, book chapters, and editorials. He performed countless invited lectures, oral presentations, and moderations. He is an editorial board of more than 10 journals. He was the mentor of lots of residents and fellows. This evening, Professor Max Aebi will give a presentation on his experiments about adult degenerative scoliosis. Well, Professor, welcome again. Now, I would like to give floor to our co-moderator, Professor Onur Yaman. Profesör Yaman.
Sesini açar mısın? Atacağım. Onur Hocam.
At the last part of this presentation, it was written there, it's a mentor of lots of residents and fellows. He is really a great mentor of me. He has never let us alone. I have learned lots of things from him. And I'm very happy to see him here again. And we can start now. Mr. Max Aebi.
It's okay. I try to share the screen.
Atacan. Paylaşım izni verdin mi? Aebi'ye.
How do I do so? Okay,
Aebi, can you share your screen?
I try.
Okay.
Hocam ben izin verdim ama herkese açık hale getireyim mi şeyi? Ekran paylaşımını daha kolay olur mu?
Max Hoca'nın var mı izni?
İzin var hocam, izin verdim ben.
Tamam.
Do you see my screen?
No, we cannot.
Deminki hocam aynı izni Alaaddin Hoca'ya da verdim. Sıkıntı yok.
No?
Yes.
You can see it now. Can you enlarge your screen, full screen?
Yeah, I do. Okay.
Okay.
No, I have to move this down. This is in my way. Okay. So thank you very much for the invitation to talk to many people I don't know. I just saw quickly the faces of them, but we'll try. It's a very strange experience to talk to a screen, but I will do my best. So my topic is adult degenerative scoliosis, which is indeed quite a big field. So how can I progress this damn thing? Oh, shit. It doesn't move forward. Oh. No, it seems it's not working, maybe. Okay, so I try in this lecture to talk and to make clear that there is this is a huge field, and the big question in this whole pathology is really how does the extent of the deformity really correspond to the measure of surgery. So at the end, I try, or I hope I can show you that there is not just one way how you can deal with these things. You have just to respect a few principles, and I think a lot of recommendations of today are relative, has always something to do with how you see this whole thing. Now it's very difficult. I cannot advance the slides. It doesn't go. I don't know whether this is the internet or what. Oh, it's coming slowly. So the treatment of adult deformity is no longer such a big technical problem. We have a lot of technology to deal with that. It is more a problem of the diagnosis and the classification systems, which are based on X-ray analysis and concept of adolescent scoliosis surgery. This is the major problem, that many people who talk about adult scoliosis, they try to apply the principles of adolescent idiopathic scoliosis. This has nothing to do with each other. These are two different pathologies. And then what is, of course, a major issue we'll try to discuss is how far to go with surgery. Is less better surgery? And only marginally I'm going to talk about outcome, because this can make a whole lecture about this. And I will also not lose my time about proximal junctional kyphosis, which is a major problem as a complication. And this is, how can I get this away? I don't know. You know, I have all the people on my screen and I don't see my screen. This is, I don't know how to handle this. Let me see how I can do this. Yeah. Okay. So there is an increasing prevalence of degenerative scoliosis in the age population. And as you all know, the aging of the population will be one of the major issues, not only in the Western world. I think this is a general problem of our world today, and we will have to deal with that. So the prevalence of scoliosis in patients which are older than 50 years is about 6%. And here are included patients with adult idiopathic scoliosis and degenerative or de novo scoliosis. I cannot advance it. What's that? I think the internet is not stable. I have to take these things out here. So the problem of this is not only that people get older and older, there is also the fact that people are more and more getting aware of this problem, because when I was a young resident or fellow, we were very rarely dealing with this problem. Today, this is one of the major issues in our clinics, at least in Switzerland and also in Canada, where I spent more than 12 years. And so this is also that the people are aware of this problem and they want to know what we can do against that. And the patient is no longer as compliant as they may have been in earlier years. That means people do not accept their limitations in the daily life. They want the solution. And as I mentioned before, this is a universal problem. This is not just the problem of the Western world. So I try to advance the slide, but it doesn't go. I don't know. Is there a solution for that? I cannot advance the slide. This has probably something to do with the internet line.
Oh.
It's not going. So you can see, for instance, when you look in the literature, you can see that when you give in the research fields, for instance, adult scoliosis, which is represented here in this graphic presentation in red, you can see that in the last years, this has massively increased, this whole thing. And parallel with that, you can see the blue one, where you can see that the sagittal balance issue has become as frequent as this, because we have learned in the treatment of this adult deformities that the sagittal balance is a major issue, even if the scoliosis we consider primarily in the frontal plane, in the from the front and not from the side yet. However, if we treat them, it is very important to understand that the sagittal balance plays a significant role in this whole thing. And this is reflected in the literature, as you can see here, that more and more papers in the scientific literature, they deal with this issue of the sagittal balance in the context of adult scoliosis. It is also clear from the literature that patients' improvement is very significant from the surgical treatment. It's much more significant than when you take medical treatment. You can see in this graph, when you go from the baseline and in the follow-up, the year 0 after the treatment surgically, 2 years, the situation is much better than for patients who have, like this dotted line, a conservative treatment. That means there is no real good conservative treatment for a symptomatic adult scoliosis. However, we have also to be aware that there is a significant rate of complications with this surgery. This is varying a lot between little complications like 9% to 66%. The complications vary between younger people and elderly people. In younger people, the the complication rate is about 1 in 3 patients has a complication, whereas in patients who are older than 50 years, at least every second patient has a complication. So this is a major issue. This is another graphic presentation just to make understand how there is a difference between a surgical treatment and a non-surgical treatment. You see that the blue one is shifting to the left as those patients who do not really profit from a treatment. These are the patients who are treated conservatively, the blue ones. Whereas the red ones, there is a shift to the right side. That means patients who have a surgical treatment, they are generally better than patients who are treated conservatively. Now, as I said at the beginning, we will not get around the discussion of classification. I think this is a key issue because we need to speak the same language. As long as we don't speak the same language, we cannot compare results. We cannot say whether something is successful or not successful. We need to understand the same thing when we talk about scoliosis. And there is a lot of things which are not so clear because there are classifications around which do not really cover the problem of the adult deformities. So the adult scoliosis can be defined as a spinal deformity in a skeletally mature patient with a Cobb angle greater than 10 degrees. This is the basic definition of an adult scoliosis. Now, there are different forms of classifications. I have tried in 2005 to put a classification together according to the etiology that has been published in the European Spine Journal. And this is, I think, very important. I know I will talk about the other classification systems which are in the daily practice important, but as long as we compare type 1 scoliosis, which is primary degenerative scoliosis, or people say also de novo scoliosis, which is basically a multi-level disc disease, you cannot compare this scoliosis with, for instance, a type 2 scoliosis, which is a progressive idiopathic scoliosis in adult life. That means under the age of 40 years, usually there is not a lot of degeneration. There is no big changes. However, when you go beyond 40 years, then you have a scoliosis also in idiopathic adult scoliosis, which shows a lot of degenerative changes. And it is difficult sometimes to differentiate between this type 3 and the type 1, but these are completely different entities. They do not work in the same way. That we have to be very clear. And this type 3 scoliosis can not only be an idiopathic adult scoliosis, it can also be a scoliosis on a neuromuscular base, a post-traumatic scoliosis, or an oblique pelvis due to leg length indiscrepancy, or lumbosacral transition anomalies, and so on. So there are mixed types. So this is a big group. Usually this group has very little to do with the de novo scoliosis, the adult degenerative scoliosis, what I'm talking mostly about in this talk. And type 4 scoliosis is scoliosis due to metabolically disturbed bone, for instance, osteoporosis, osteogenesis imperfecta, or tumors like multiple myeloma, which can affect the bone in a way that this may lead due to fractures to scoliosis. It is very interesting that Marty Boumarin, a French orthopedic surgeon, he made a classification in 2007. That means 2 years after we have published our system. And he concluded that there are 2 main types, a so-called adolescent scoliosis, which is in the adult life. As I mentioned before, this is the type 2 in the classification I presented, and which continues to progress in the adult life. So not every adolescent scoliosis will stop by the end of the adolescence when the people are adult. This has also been taught when I was a resident or fellow. We have been taught that an adolescent scoliosis, which is stable with 20 or 25 years, will not progress. This is not true. This is not true. There are adolescent idiopathic scoliosis which progress into the adult life. And So the other type is this so-called late onset scoliosis or de novo scoliosis, which he calls type B. So he also makes this differentiation exactly the same like I have proposed. And these are two distinct entities. And it's interesting that the translatory subluxation with rotation on the base of a disc degeneration seems to be the initial element of the progression for the type 2. That means the de novo scoliosis. While in the idiopathic scoliosis, this is much more the consequences of the progression, that the rotation, the increasing rotation is the consequence of the progression and is inherent in an idiopathic deformity. Scoliosis, there is a rotation. This is not a two-dimensional deformity. This is a three-dimensional deformity right from the beginning, whereas the de novo scoliosis at the beginning usually is not a three-dimensional deformity. It's presented very well in just the frontal plane. The menopause constitutes a period of deterioration for the type B, that means the de novo scoliosis, and the progression of the adult scoliosis usually is linear. It can be used to establish an individual prognosis. You can a little bit forecast what you have to expect in a specific patient. Now, let me give a few examples and try to explain with these examples what my message is. This is a perfect example of a de novo adult scoliosis, that means a type 1. This is the natural history, and you can see that the patient, when she was 33 years old, I saw her, and she had 8 degrees. If you measure that, this is almost unmeasurable. By definition, this is not a scoliosis. 17 years later, this patient had a curve already of 25 degrees. You see the classical signs, the translational dislocation and the rotation in the apex. And 5 years later, the patient has a significant deformity with an apex deformity of major derotation and with major translational dislocation. And clinically also the patient has a claudication symptomatology. That means she had radicular symptoms in the context of this whole deformity. Here we see an adult idiopathic thoracolumbar scoliosis. This is an idiopathic scoliosis which progressed in the adult age, and you can see basically this scoliosis. Also, it's in the adult life. It's treated more or less the same way like you treat an idiopathic scoliosis in the adolescent age. This is a patient, another patient of 45 years who presented with this scoliosis, which is a double curve, and this is an idiopathic curve, which goes into the adult life. And you can see when you do the traction film how you can reduce it, but even in the reduction, you can see the major rotation of this lumbar spine. Each of these vertebrae has a significant rotation, those vertebrae which are above of L4. So this is by nature a three-dimensional deformity, which is an idiopathic scoliosis. The treatment, as you can see on the right side, is like in the adolescent age. This is another secondary degenerative scoliosis. So this is a type 3, as I mentioned. As you can see, this is quite a significant lumbar scoliosis. The rotation is not very significant because it's not an inherent idiopathic scoliosis. It's primarily a deviation to the side because of a oblique pelvis, and the oblique pelvis is due to a hip problem. That means this patient had an arthrodesis of the right hip, and this arthrodesis was not well balanced with the contralateral hip. And the sequence of that, of course, is a deformity in the frontal plane, which then with the time will also show rotation in the apex and dislocation in the apex, as I mentioned before. This here is a type 4. This is a metabolic scoliosis, if you want. That is an osteoporotic deformity, because you can see that this patient has a unilateral or more exposed fracture on one side, which leads to a deformity. Again, you can see this is an early stage. There is no rotation of the vertebra above and even on below. So this is in the frontal plane, a deformity mostly on the right side, which leads to this scoliosis. And because it's a wedge type fracture, you also have a kyphosis, as you can see in the small image in the right up corner, and you can see the MRI in the exposure for the water. You can see that this is a pretty fresh fracture. And here, of course, the treatment is simple. You don't want to stabilize that and create more fractures by rigidity of a stabilization. This patient has just been treated for this fracture, and you can see there is a acceptable alignment of the spine in the frontal as well as in the lateral projection. This is another example of a metabolic type 4 deformity. This is a 60-year-old patient who had a lymphoma with bone fragility, and you can see there is scoliosis as well as kyphosis. So this patient has been treated with multi-level kyphoplasties, but it was not possible to correct her specifically in the sagittal plane. And as you can see with the traction film, and traction films are very crucial in this kind of evaluation of patients, you can see that this is an axial instability because you have air everywhere in the discs. So the combination of this axial instability and the sagittal malalignment made it necessary to do a major correction, even with a subtraction osteotomy, as you can see on the right-hand side. And with this stabilization, the patient was quite happy, and she's still doing pretty well after several years now of this fixation. Now, I don't expect that you want to learn this by heart, what I show you here. I only want to show you this is the classification of the SRS, the so-called morphological classification, which has been published in 2006. This classification is not very helpful. It's very complicated, and there is also things which are evident. You know, we know that there are thoracic curves, there are thoracolumbar curves, and there are lumbar curves, and there are primary sagittal plane deformities, but it doesn't help. This whole thinking here in this classification is the concept of the idiopathic scoliosis. And I do not think that with all the so-called modifiers, this is a very helpful classification. I think we have to get rid of this concept of thinking of idiopathic scoliosis. This here is an improvement of the SRS classification. This is the Schwab adult spinal deformity classification. This is a classification which can be applied obviously in all the adult scoliosis. That means whether they are primarily idiopathic and secondarily degenerated, or whether they are primary de novo degenerative scoliosis. What is very important to understand is the so-called sagittal modifiers, as you can see on the right-hand side. There is a pelvic incidence minus the lumbar lordosis. When this is within 10 degrees, then this is okay. This is more or less balanced. If there is a difference of more than 10 to 20 degrees, then this is a moderate disbalanced spine. That means something we need to consider when we treat this patient. And when it is more than 20 degrees, this difference, then this is a marked problem of the sagittal balance, and therefore this needs to be integrated in the treatment plan. The same thing is true for the global alignment, which can be defined by the SVA. There are other global alignment parameters, but this is the most frequently used. And finally, the third one is the pelvic tilt. The pelvic tilt, which gives you an understanding how much the pelvis is retroversed. That means when the pelvic tilt is less than 20 degrees, then this is fine. The balance is pretty good. In this lumbar pelvic classification, which is very important, this is an entity, the pelvis with the lumbar spine. And when this pelvic tilt is more than 20 to 30 degrees, then this is a moderate disturbance of the pelvic tilt, that means of the retroversion. And if it's more than 30 degrees, then this is a severe deformity, and therefore this needs to be very clearly considered in the treatment. So I think this here, this part of the classification, which has been done by Frank Schwab, is important for the understanding. It helps you once you have defined this is an idiopathic adult scoliosis or this is a de novo adult scoliosis. Now, I show you some examples here. This is a typical adult idiopathic scoliosis, as you can see. And this is a so-called coronal curve type L1. The L, that means a lumbar spine. And here this is moderate. There is only a little bit increased the pelvic tilt, a little bit increased the difference between the pelvic incidence and the lumbar lordosis. So this is something which you can probably treat without any additional measures, just by instrumentation when you need to really treat these patients. Here, this is a double curve. This is a D type in this Frank Schwab classification. Again, this is a typical adult idiopathic scoliosis and not a primary degenerative de novo scoliosis. But you can see, all these curves, you can basically separate in the elements of the curve, of the pelvic incidence, and of the pelvic tilt. This is very important for the sagittal alignment. Now, there are radiological parameters which are very typical for adult, in particular de novo degenerative scoliosis. This is very typical for de novo degenerative scoliosis. When you take very progressed adult idiopathic scoliosis, you can find sometimes the same thing, but I will show you these elements in several examples of de novo scoliosis. So these are very typical. So very typical is that you have in the so-called obliquity angles. That means you have an apex, and this apex is created by oblique end plates of the adjacent vertebra. The plumb line is usually offset between the line between T1 and S1. So you are outside of that, even if in general, the whole spine seems still in the frontal plane adjusted. And the second very important issue is the issue of the translational olisthesis. And you can see that when you take these issues, then relevant is the olisthesis. That means the translational dislocation in the frontal plane, the end plate angle of the vertebrae which form the apex, and of course the lumbar lordosis and the thoracolumbar kyphosis. These are important, relevant radiological parameter. Non-relevant is in this case, in fact, the Cobb angle. This is not really relevant, and the H and the level of the olisthesis and the plumb line offset is not relevant for this specific classification. Here is another example of an degenerative adult scoliosis, which is now a real degenerative scoliosis. As you can see in the middle of the picture, you have this typical translational dislocation. You have the obliquity of the vertebrae, the end plates of the vertebrae around the apex, and you can see that the lordosis is diminished in comparison to the pelvic incidence. Here is another example of a patient with a mild scoliosis. This is a psychiatrist. He had a terrible pain. He complained about pain, but when you look at the X-ray, it is not really very impressive. As you can see, there is a curve which has 25 degrees, and this is not really a lot. And when you take the pelvic incidence, which is 57 degrees, and to take the lumbar lordosis, then you can see that there is about 17 degrees. That means there is a moderate disturbance in the sagittal alignment, and the SVA is even 0. But when you see at the MRI, which is in the right upper corner, you can see that this patient had a significant narrowing of the spinal canal in the apex area, and this was a part of his pain. And of course, you can discuss whether you want to just treat this massive disc and flavum hypertrophy, but probably this will not last very long. And with the constellation, as you can see now on the right picture, you can see there is a picture of traction. And when you see this traction film, you can see that the discs, at least L3-4, L2-3, L1-2, are filled with air. That means there is again an axial instability. And if you go and just do the decompression, probably you will not solve the problem of this patient in a long term. And you can see that when you analyze this different scoliosis, the de novo degenerative scoliosis is the most frequent form of adult scoliosis. This is the most frequent form. It's not the idiopathic scoliosis. Idiopathic scoliosis is relatively rare, as you know, from the adolescent. However, the de novo degenerative scoliosis is a very frequent pathology, as I said at the beginning, because this has something to do with the age. And you can basically break it down with a slogan and say, a de novo degenerative scoliosis is a general multi-level disc disease. It's a disc disease, and all the rest are consequences of this disc disease. Now, people have understood that, and specifically Berjano and Lamartina, the two Italian surgeons from Milan, they have spent at least Claudio Lamartino has basically spent his whole career with studying adult scoliosis. He is a former fellow of mine in Montreal. He worked with me in Montreal at McGill. And he has his partner, which is Berjano, and they have tried to analyze and to classify this specific de novo scoliosis, because these are frequent problems in the daily practice, and they want to give something to help decisions to make them easier. And this is the classification. And again, you don't need to read everything. You can see what I mark with red. Again, there is a type 1, a type 2, a type 3. Type 1 is a localized, localized degeneration of the disc, which leads to a deformity. The type 2 is a localized degenerative disc disease at the apex of the curve. This is very important, at the apex of the curve. And the type 3 is a degenerative disease multi-level, which goes beyond the apex, above and below. So this is a more extensive pathology within the curve, what you see. And then you have the type 4, which is a pathology where you have, in combination with the frontal malalignment, with the frontal deformity, you have also a loss of lordosis. That means you have a sagittal unbalanced spine. And when you take the type A of this group 4, then this is only in the sagittal plane imbalance. Whereas when you type the type 4B, you have a sagittal alignment pathology as well as a frontal plane pathology, as you can see here. So on the left side, the type 1 is very simple. The pathology, as you can see, is at the level of L4-5, and this leads to a curve. So you don't treat this curve, you treat the local problem there. Then the second group, the type 2, is the deformity or the degeneration. The most impressive degeneration is at the apex. The type 3, you can see there is multi-level degeneration. So this is a more extended pathology of degenerative disc disease. And then you see the imbalanced spines. That means the type 4, the type 4A with a severe sagittal malalignment, and the type B, type 4 is a B type with a major also frontal malalignment. That means the plumb line out of the center of the head is falling far beyond the midline of the body. So what are the clinical presentation and the preoperative evaluations? Pain and symptoms correlating with objective findings. We have to understand there are pathomechanisms behind that, and there are pathomorphology behind it. So the morphology on one side, of course, determines to a certain degree the mechanism, and the mechanism determines to a certain degree also the pathological morphology. So clinically speaking, when you see these patients, and then of course you have to ask several questions, like whether they had previous surgery, whether there is vocal deformity, whether they have compensation mechanism. And as you can see on the right-hand side, this photograph of this patient, what you have to look at is, first, is this patient standing in a position which suggests that he has compensation mechanism. When he has compensation mechanism, something is wrong in the sagittal alignment of the spine. So you see there is a flexion, a mild flexion in the knee, there is a mild flexion in the hip, and you see that there is a flat lumbar spine. And of course, as a compensation, you also have sometimes a flattening of the thoracic spine, but this also can be fixed in a kyphosis. Then the patient, of course, is falling much more in front. And of course, you look at the pelvis. And when you look at the pelvis and the patient stands like this in front of you, look to him from the side, you see that the pelvis is retroversed. That means it's tilted backwards. So these are clinical elements which are very clear when you have to answer the question whether you want to treat this patient. And of course, there are all the other things what I listed here relevant when you make this indication. Now, the pain, of course, is not just a simple thing. The pain is very complex. So you have a back pain portion. Most of these patients have back pain, 40 to 90%. The pain can be at the apex. The pain can be a referred pain, which is not a radical pain. There are maps of referred pains, which you can go and see in the legs, in the lower extremities, in the back, and so on, which have nothing to do with the radical pain. This is a referred pain, which is created by, for instance, the facet joints or by disc pathology. Then, of course, you have the radical pain. The radical pain can have its origin from the concavity or from the convexity of the curve. And the pain can be due to spinal stenosis in form of claudication. And the pain can be associated with sagittal compensation or decompensation mechanism. As I showed you this patient before, when you have a flattening of the thoracic spine, this is a compensation mechanism. This works with muscle force, and these muscles get tired. And as they get tired, they become painful. Now, you see there is, of course, the neurological signs and symptoms, which we have to understand. Then there is what I showed you before, the so-called axial instability of the curve, whether the curve is slowly collapsing or not. And of course, there is the translational instability with the degenerative changes, facet joints, the disc, and finally a rotatory dislocation, as I showed you before. And of course, you also have to look at the curve progression when you when you analyze the pain pattern. Now, of course, there are many ways you can do X-rays. There may be, for sure, functional X-rays. That means bending and traction films. There may be MRIs. There may be myelo-CT, specifically when you want to see the joints, what the role of the joints is in the context of the spinal canal. It is it's preferable to do a myelo-CT, and you can do when you do a myelo-CT, you can also do a functional myelogram. That means you understand then also if the pain is not a static problem, but it is a functional problem depending from movement and position. And of course, you have to understand the risk factors. You have to analyze osteoporosis or osteomalacia, of course, the age, the pre-existing degenerative disorders of the spine, which may not have to do something with the actual curve. And when you look at the degenerative pathomorphology, then you have to look at the discs. You have to look at the facet degeneration. You have to look at irritation of neural structures through the morphology, whether this is static or whether this is dynamic, at which level, several levels, one level, and of course the osteoporosis and the very important spinopelvic parameters, as I mentioned before. And many of these elements, the disc, the facets, and the dislocations and the neurostructure compression, you may need invasive evaluation by infiltrations. You may do discograms, you may do facet blocks, you may do epidural blocks, you may do sacral block to figure out from where the pain may come and whether you can limit your surgery, maybe just at the source from where the pain comes, and whether you have to combine it with a more global picture of the deformity. This is a very important question. And here, just briefly to remind you, this so-called spinopelvic harmony is a central issue today when you deal with deformities, even the major deformities in the frontal plane, as I mentioned. This is a chain of interconnected parameters. That means you have a thoracic kyphosis, you have a lumbar lordosis, you have a pelvic incidence, and you have the SVA, and you may also have a parameter which is thoracic 1 to sacral pelvic incidence or inclination, and this gives you a global picture of the deformity of the spine in the sagittal plane. And I may just tell you, for interest, if you are interested, you can go and figure out why the pelvic incidence is the sum of the pelvic tint and the sacral obliquity. That means the obliquity of the sacral end plate. So when you take these three angles, they are interconnected in the form that the pelvic incidence is the pelvic tilt and the sacral slope. I will not explain that. This is a geometrical issue, but I'm sure that many people who talk about this, they don't really know how to measure or how to evaluate that, what that means, but it's always written about that. Now, the sagittal imbalance is, you can see that when the patient is prone, this is when clinically, as I showed on the picture before, and it is a fact that this sagittal imbalance is gradually deteriorating also with the frontal deformity deteriorating. And this has something to do with a loss of anterior column height with the time, because in degenerated spines, what we see is a loss of the disc height and finally a loss of vertebral body height. This can be due to very mild compression fractures of the vertebra or the rotatory subluxation, and then you have a different height in the front, and therefore you have a very slow collapse of the anterior column, which will finally express itself in a kyphosis. And of course, this may be even worsened by adjacent joint arthritis and spinal stenosis, because you may have a deformity overlapping the pathomorphological deformity just by function. I will show you a case after that. This is important to understand. So the X-rays, very quickly to summarize, you want to have whole spine X-rays. The best, obviously, today is to use the EOS system, and you can understand also the compensation mechanism. You can delineate areas of stiffness and synostosis. I will come back to that because this is relevant for the treatment. And you can also understand the function of the muscles on one side and the lumbosacral alignment. That means the pelvic lumbar unit. And this is important, as I showed before, for the whole deformity understanding. Now, very simple to understand what happens here when we talk about these deformities, about this adult, degenerative, de novo deformities. So what happens primarily is an asymmetric degeneration of the disc. The asymmetric degeneration of the disc may be a consequence of an asymmetric loading. And the asymmetric degeneration certainly leads to an asymmetric loading. And the asymmetric loading and the asymmetric degeneration is obviously combined or is expressed then in an asymmetric deformity. So you have this element, asymmetric degeneration, asymmetric loading, asymmetric deformity, which goes in circles. They connect with each other. And this is all a consequence of the degenerative changes in the spine, which leads finally to the adult scoliosis. And when you look at the clinical expression of that, then you have on one side a deformity being a scoliosis or kyphosis. You may have an instability, as I showed. It can be a frontal instability, it can be a sagittal instability, it can be an axial instability. Then you may have a stenosis, which can be central or recessal, and you may have a progression. And this is certainly given by mechanics, changing mechanics, or the bone metabolism like osteoporosis. So these are the four pillars to understand the clinical pictures, and you have to analyze that. You don't use the SRS complicated classification, which does not tell you anything about the functional problem of this deformity. But these elements, is there instability? Is there stenosis? Is there a deformity which can be explained by the radiological picture? And is there a progression? This gives you the clinical picture. The clinical picture is pain, claudication, neurological deficit, and very rarely, and almost this is not relevant, is the cosmesis. The cosmesis is the major issue in the adolescent is idiopathic scoliosis, but certainly not in the adult degenerative deformity or the de novo scoliosis. Now, let's see a few case examples to exemplify what I tried to explain more theoretically now. So we will have now a few cases to discuss. You know, medicine is not an exact science. Medicine is a narrative science. So you can have theories as many as you want, but at the end of the day, you have to deal with the actual case, with what you see, with what people tell you, what the patient complains about. So this is not an exact science. So every discussion about what we lead in medicine has finally to apply to patients. Now, let's go back to this 5 or 4 types. That means that the type 4 has 2 subtypes. And let's take some example. Now, this is a very interesting example because this is indeed an adult idiopathic scoliosis. This patient had had the scoliosis all his life, but suddenly he came in with a significant neurological deficit. He had almost a cauda equina syndrome. And when you look at this, you can see that there is a type 1 non-apical problem, disc degeneration. And you can also see on the right side that the patient is leaning forward. That means he is sagittally not balanced. Now, the question is that the problem of his pelvis or the spinopelvic harmony? We learned by treating this patient that this is a functional malalignment of the sagittal balance. So this is not in the structure. This is only functional. As you can see here, he had a complete block on the myelogram at the level of L3-4. And you can see that also in the prone position. In the prone position with the myelogram, you can see that the scoliosis is even partially correcting. And when you see this patient standing, then you can see that his problem is L3-4. And he has been treated only at L3-4 by removing the compression. And you can see that the patient had a secondary realignment without doing anything else. Of course, he has other degenerations, but this major problem was at L3-4. And once this has been removed, the patient went back in a reasonable sagittal alignment, and he had never had a pelvic retroversion. Now, this is another interesting patient with a degenerative deformity. Again, this is a type 1 because the problem is where you can see there, it is at the L3-4. It's not at the apex of the curve. And by treating only this part, that means this level L3-4, by a lateral minimal invasive approach, this patient has been basically cured. Of course, she has significant degeneration below and above, but this is not her problem. Her problem was the problem at L3-4. She had a radicular symptom, and these radicular symptoms were dependent from activity, from movement, and also from position. Again, this is a de novo adult scoliosis with a type 1. This is not a non-apical disc disease. So the apex is one level higher. And this disease was with a more or less compression, spinal stenosis. This was a polymorbid patient. We did just a decompression and the translaminar screw fixation to fix the joints. So the joints couldn't do any translation anymore. And that was sufficient. We did not do any correction of the scoliosis. This doesn't make sense in this elderly person who had this problem just at the level of the underneath the apex. Here, this is another type 1, again, different. You can see there is a scoliosis above in the lumbar spine, but the problem is far away from the apex. It's in fact at the level of L4-5, as you can see on the MRI on the right side. And by treating this level, the patient was more or less cured. What will happen over time with the scoliosis, which is above? This is another question, and I will show you some cases where you can see that sometimes this problem is not resolved with a surgery, one surgery several years later, the next problem may occur because the spine is usually damaged not only at the level where you have the major problem, but you have a degenerated spine. Now, this is another patient, 84 years old patient, which of course you don't want to do major surgery in an 84 years old patient. So you have to analyze exactly what really the problem is. And again, in this patient, this is a problem basically on this curve. This is a type 3. That means she has several levels which are diseased with spinal stenosis, as you can see on 2 levels. And the sagittal alignment for this 84 years lady is not bad. That means you can handle this problem just at the level where the pathology is. And you can see that you don't need to treat the lower level L4-5 and L5-S1 because they are spontaneously fused. So you can concentrate on the level above. So that means the principle that in a type 3, you should basically fuse the whole extension of the scoliosis is not true when you have this kind of pathology like here, where you have already a fusion, a spontaneous fusion, so you don't need to do anything there, and therefore you can limit your surgery as we did here. Of course, we didn't correct the scoliosis, but this patient was very happy with 84 years. I have seen her 2 years after the surgery, and since I haven't seen, I don't know whether she's still alive with 86 years or 87 years today. Of course, there are different possibilities to die with all these corona questions and so on. But she was very, very happy with this limited surgery, and we did not touch the whole scoliosis. Now, this is another type 3. That means an extended multi-étagère degenerative disease, which goes over the whole curve. This is a 74 years old lady. And when you look at her in the axial, look her at the traction film, what you see here in the middle, then you can see that again, there is air in the discs. There are at least 3 discs which are not stable in the axial load. That means this spine is not stable. And so if you really want to deal with this problem, you have to consider the whole curve. And therefore, in this specific patient, you have to do an extension of the whole curve, as you can see here. And as this patient had a relevant osteoporosis, she was a very strong smoker. We did prophylactic kyphoplasty or vertebroplasty around the end vertebra, which was fixed to try to avoid an adjacent segment problem or an adjacent kyphosis, which may happen even if you think that the sagittal alignment is good. So with this patient, it worked out, but there are some patients where this does not work out at all. So the additional problem, as I said, is the prevention of the junctional kyphosis due to osteoporosis, and also the distal junctional kyphosis. So that means we went down to the sacrum. As you can see, the fixation goes in the sacrum because the level of L5S1 was severely degenerated in this specific patient. Now, this is another type 3 extended. That means the whole curve has several degenerated discs. As you can see here, this is only a 56 years old female patient. You see the MRI below. So the discs are black. The disc L5S1 is still quite good. So the rules here is usually you do a fusion from the end to end vertebra of this curve. That means you include all the diseased discs. Then you can argue whether you have to take the sacrum. So if there is a pathology L5S1, you better include it, but there are different opinions about that. As you can see here, this patient has been treated only to L5 with a combined procedure, lateral cage by X-lift approach and posterior fixation with percutaneous fixation. So that is to demonstrate the individualization of the surgery depending on what you want to reach. This is still a younger patient, 56 years old. You want to make her a stable spine, a spine which allows her to do a normal life. And usually these people, even they want to do sports and skiing. As you can see here, this is the 1-year follow-up with the parameters which are quite satisfying. Now, this is again a type 3, but again, we have to look here in a different way. You can see there are several levels, and you have a pretty good disc at L5S1. And this patient has been just treated at the apex, even with the disc above and below also in some way involved. Whether this will keep in this way over a longer time, this is difficult to say. There are, of course, some discussions about these cases sometimes, and also some patients, they do not want at all a long fusion. They want everything to keep it as small as possible. So for the moment, this patient is doing well, but there is good chance that she may have another problem above and below in the next future. Now, this is a type 2, if you want. That means you can also say this is a type 3 when you really count the discs which are involved. But in fact, the major problem here is at the apex, as you can see. And this patient has been treated with a very minimal invasive surgery. As you can see on the left side, there is pedicle fixation, and on the other side is just a blockage of the joints with translaminar screws to basically stop the rotation and the translation in the joints. And you can see that this patient here is 3 years after the surgery. He did for this 3 years pretty well, but you can now see that he starts to degenerate the level above. That means at L2-3, and with time, as you can see, there is a progressive curve. So again, that's what I mentioned before. Sometimes it's difficult whether you want to prophylactically include already a beginning degeneration of the disc above to avoid the secondary surgery, or whether you want to take the risk. And you can have, you may be wrong in both ideas. Sometimes you are surprised that the patients do not develop any degeneration, and sometimes they develop very quickly. So this picture on the right side is 12 years after the first operation, and then that's the operation which has been done. This is now 12 years after the first operation and 6 months after the second operation, the extension. And as you can see, there was a quite significant spinal stenosis in the level of the adjacent segment. Now, this is a type 4. As I mentioned before, you can see the severe sagittal malalignment with a frontal deformity in the sense of de novo scoliosis, a minor one. And of course, this problem here, you have to solve with, if you want to solve it, if you want to realign this patient, you will not get around some osteotomy. Here in this specific case, it has been pedicle subtraction osteotomy, the corner type, which has been made with a long fixation. So you can also handle sometimes these problems with shorter fixation, but you always go the risks that the patient develop a adjacent segment problem. That means an kyphosis above. Here, this is a patient of 58 years, as you can see, with a significant lumbar scoliosis. This is a type 4B because you have a malalignment in the frontal plane as well in the sagittal plane with a short fixation and a pedicle subtraction osteotomy. As you can see here, this patient has been treated, and she is now 6 years after the surgery, and until now there has been nothing to be necessary to be extended. We were always observing, obviously, the superior end of the fixation, but for the moment everything is quiet. Now, this is another patient with a type 4B, that means frontal malalignment and sagittal malalignment. And again, this is a patient where you need to do osteotomies and with long fixation. If this patient is well balanced, it may be okay. If the patient has a minor disbalance, you may end up with a problem at the end here with a junctional kyphosis. But again, sometimes you are surprised that there is no junctional kyphosis, and sometimes there is. Now, the rules in type 4 is obviously you have to restore the sagittal alignment. That means the mismatch between the pelvic incidence and the lumbar lordosis. You have different possibilities like PSO or anterior release techniques to do that. And you can also restore the anterior column with cages, with anterior releases, and maybe you can avoid an osteotomy because osteotomies obviously have also their risks and specifically also the bleeding. So what means the adjacent segment problem? And I show you here just a patient which is very, very exemplary for this issue of the adjacent segment problem. I think you can better understand when I show you this case. So this patient has been operated the first time in 2003. The patient had most significant degenerative problem at L455S1 with spinal stenosis, and we did just a decompression and a translaminar fixation with a fusion. And you can see there that the disc at L34 already is asymmetric. Now you see this patient 4 years later, you have now definitely a curve starting above. So this is, we did the surgery probably here, not at the apex. That means this was primarily a type 1. And over time, then, of course, it became much more than a type 1. So again, you can see 2007 with the deformity, 2009, the deformity has increased, and this is now including the disc spaces above also. And finally, you can see the bending view to the right, the bending to the left. So there is some correction of the scoliosis, and you can see here the treatment just with one level above. This was in 2009, so that means 6 years after the first surgery. This is the CT after the surgery because the patient continued to complain, and the patient came back more or less with back pain, and that you can see the level above the fixation or the level 2 level above. That means there is an intermittent segment which is not so severe, but you can see that now there is a translational dislocation here and also some rotation. So there is a new apex here evolving, and you can also see that the sagittal plane here is very poorly aligned, And you can also see the MRI with spinal stenosis. And finally, this patient has been restored with a fixation higher up. And I would say, unfortunately, we did not do the fusion with pedicle screws to the sacrum. We left this fusion L455S1 as it was. And so this is now 9 years after the surgery on the right side. This here is basically 12 years after the surgery, and you can see that the patient develops now more or less a problem at the lumbosacral junction. What is probably the most relevant problem, because the patient complained about more back pain. Finally, we had to do the fixation down to the sacrum, and you can see on the left side here a terrible sagittal alignment in a frontal alignment, which is quite good. And we couldn't understand why this kind of malalignment was in the sagittal plane. And finally, we figured out that this sacral screw here was in the iliosacral joint. And this was creating such a pain that the patient reactively went in this poor sagittal alignment. And when this screw has been replaced, as you can see here on the right side, the patient went back in a very satisfying sagittal alignment. So that means we have to understand all this mechanism between the lumbar spine and the pelvis when we want to understand the malalignment of the spine. And as you can see in this case, this is now the picture on the right side in 2020. That means 17 years after the first surgery. The patient is now 76. She is doing more or less everything for her age, and she's quite happy with the situation. But as you can see, you start with a small surgery and you may end up with a major surgery. So there is another unusual case, which I think is interesting for you to understand. This is a 72-year-old female physician. She had this scoliosis. She had mostly back pain, standing and sitting. It is not so clear whether this may have been some sort of an idiopathic scoliosis from use, which has deteriorated and degenerated, or whether this is really a de novo scoliosis. But you can see that the patient has a frontal and a minor sagittal malalignment. This patient had traction films. Again, you can see the air in the disc, so there is a certain tendency of the collapsing of the spine. And also the bending shows some instability. And this patient has been operated in this way. And she was very, very happy, maybe for 6 months. And after 7 or so months, she came back. And she complained about severe neck pain, not back pain, about severe neck pain. So we evaluated the neck. As you can see here, she goes more and more forward. And this is the picture, what you can see. You can see that there is a dislocation between C3 and C4, which was before the surgery, not there. So this is really a secondary problem. So what happened here? It happened, this is basically a junctional kyphosis, but the spine between the fixation and the lower cervical spine was so rigid that there was no possibility to go in a dislocation. So the first level which was possible for this was C3-4. That means that somewhere in the brain, there is a mapping about the posture we have. And obviously nature tries to go back in this specific form. So this is a very instructive case that you cannot just consider the lumbar and the thoracic spine. It may also affect at the end of the day, the cervical spine. As you can see here, this is the MRI. And finally, we had even to fix this one because the patient started to have problems in the hands and shown some myelopathic signs. So this is another very interesting patient. What we can learn something about these forms of scoliosis. This is a 77-year-old female patient, which in frontal plane was almost balanced, but very unbalanced in the sagittal plane. She was overweight. She was multimorbid. She couldn't take a major surgery. And so that's the picture, what we have here. And as you can see, there is a malalignment in the sagittal plane. In the frontal plane, she has a curve, but it's not so bad. And this is the MRI. She had a significant also spinal stenosis, mostly recessional stenosis on the side of the concavity. And we basically did a surgery in this patient. What everybody would say, you shouldn't do that because she has a multi-level problem there, and you cannot just go do with one fixation. This will collapse. But this patient is 3 years after the surgery. You can see that with one level where the most stenosis was, we did a correction with a pedicle fixation. We didn't do an anterior cage because the patient couldn't take a major surgery. So we just opened it and it didn't fall back. It didn't fall back probably because the sagittal alignment, as you can see, is in the rather posterior part of the lumbar vertebral column. And we just fixed the adjacent segment below. The patient was complaining about 2-3 years after the surgery about pain in the adjacent segment. That means above and here below, but not in a way that she would need another surgery. So the surgical treatment is a complex one, as I tried to demonstrate with cases that there is not just a cookbook you can do that. You have to analyze the case and to see what fits best for the patient and how best the patient can take the surgery. So how much correction you want, how much decompression, how many segments you want to include, how much you need to do for adjusting the sagittal as well as the frontal balance. Do you need to create additional lordosis? How rigid the fixation has to be? And of course, because these are elderly patients, you have to always ask the question, what can you do to minimize the surgery and to make the patient, in fact, better and not worse with your surgery, because there are complications. And you can see here, this is a major study where you can see the complications in patients between 25 and 44 years in scoliosis surgery. And so overall, this is 17%. If you go with patients who are 65 to 85 years, though this jumps to 71%, that means you have about 42% of minor complications and major complications. Almost 1 out of 3 patients has a major complication in this kind of surgery. So one of the big questions obviously is, how do you create the lordosis to minimize the surgery? That means, of course, you can always create lordosis with an osteotomy, but osteotomies may bleed and they may not be appropriate for certain patients. So there are different ways you can do a lordosis. That means you can do optimal posterior and anterior release to mobilize the spine. You can use a pedicular system where you can contour the rods and where you can adjust the angles of the screws. That means you want to do that with polyaxial screws. So you can use the corrective power of that. And of course, you can always try to do an anterior column reconstruction with cages. And there are specific cages today. I will quickly show that. And finally, there are the osteotomies. You can do multi-level Smith-Peterson wedge osteotomies, or you can do pedicular subtraction osteotomies or modification of them. So here, just to overview, these are the alignments. What you can do with the arthrectomies, that means you do the joints release, then the Smith-Peterson, the pedicular subtraction, and even the vertebral column resection. With that, you can also correct, obviously, a kyphosis. And with anterior lengthening techniques, and anterior lengthening techniques are today specific cages. And of course, with correcting maneuvers, that means you derotate, you act against the translation, and you can do that partially with in situ bending of the rods. So this anterior lengthening techniques, when you want to do that, you need to have a strong anterior rim of the vertebra. That means in an osteoporotic bone, this doesn't really work well because these cages may sink into the bone. But as you can see here, with specific cages which have create a lordosis of 18 by 30 degrees, you can do this. But that means your support, that means the vertebral body, specifically the rim, the outer rim of the vertebral, must be strong, otherwise they will sink. Here is an example of such a correction of a patient. And also I have to remind that when you want to correct lordosis with this specific technique, then this is, of course, the technique you can apply in the L4-5 and L5-S1 segment, because about 60% of the lordosis in the lumbar spine comes from the lower two levels. So when you have powerful cages for a posterior or for an anterior approach or a anterior lateral approach, then you can certainly do that with this technology, and you can limit that in the lower spine, and you can get quite a good correction of the lumbar spine. So that means when you do this kind of surgery, you can today do that with these mini A-lifts, with these specific cages. You need to know how to do this kind of surgery, or otherwise you need to have an access surgeon with you. Of course, you can have major complications when you are not familiar with these techniques. Here you see a work of Berjano with complications of this lateral approach for the specific cases. That means at the level of L4-5, L3-4, L2-3. And so with these techniques, you can do today minimally or less invasive procedures with less blood loss, less traumatic things, possibly less complications if you do it well, but you can have major complications if you do not really master the technique. So this can be a lateral or an anterior surgery with cages, or it in combination with a posterior percutaneous pedicle fixation and stabilization. So this is the case I showed you right at the beginning. This psychiatrist, this patient has been treated in this way. So he had a very limited decompression at the level of L3-4, and the pedicle system has been put percutaneously, and the cages have been done with an XLIF approach. So he had a blood loss of about 200 milliliters in these two surgeries, which were done in the same anesthesia. This is another example of a patient. This is a 56 years old female patient with this classical scoliosis of de novo scoliosis with a flat back. And as you can see, she has a restored sagittal alignment. Again, percutaneous posterior surgery and XLIFs with small accesses. Again, here the blood loss was about 250 milliliters. This patient I know pretty well. She is doing skiing today. She's now almost 60 years old, and she goes skiing with this fixation. So that's quite encouraging. Now, to finish, there are many recommendations what you have to do in this kind of pathology, and there is a paper from Da Silva and Lenke about the so-called 6 levels of operative treatment of adult scoliosis. And there is, of course, you can do decompression alone, you can do it with limited instrumentation posterior, you can do it with longer fixations. You can do an anterior release in combination with posterior instrumentation. You can do long fixations. You can do it together with osteotomies. All what I tried to explain to you. But I think you cannot just go from a scheme like that. As I said several times, you have to analyze the case with the elements I tried to show you, and to make an analysis and to make basically a plan for the strategy of the surgery. And all this is maybe helpful when you compare with other kinds of surgeries, but it will not prevent you to really analyze the case and answer the questions of the image, the clinics of the patient, the history, and the expectations of the patient, because very often there is a polymorbidity. So, usual recommendations are short fusions are sufficient for patients with small Cobb angles. That means type 1, type 2, according to Berjano, sometimes type 3. Long fusions, when more severe Cobb angles, and specifically also in a sagittal alignment or malalignment with adjacent segment problems. And when you have severe sagittal imbalance, you may need spinal osteotomy. And you have to be very clear about the high-risk patients And in this kind of high-risk patients, you have to be careful with long fixations. Very often, even well-balanced, they may break above, they may do a superior adjacent segment kyphosis. So patient makeup, history, clinical finding, imaging, and the balance. These are the elements you always have to ask about when you make a decision for a surgery. So in conclusion, scoliosis in adult life has different etiologies and different clinical presentations. The conservative non-surgical measures are of limited success, almost non-success if you want. When there is progression of the curve, instability, induced back pain, radicular pain, or claudication, or neurological deficit and disbalance, surgery is certainly the only realistic option. And the treatment needs to be customized according to the needs of the patient and prognosis. As I try to show you with these cases, that there is a clear place for an individualized surgery, and do not treat X-rays. You know, we are very, very much in the tendency that we treat X-rays, and it's always very beautiful when you have a very nice X-rays after the surgery, but whether this really serves the patient is another question. So that's about what I have to say to this topic. Of course, you can speak the whole day about that. This is a very important part of spine surgery today in a spinal practice, at least in a center practice. Thank you very much.
Aebi, thank you so much for this clear and understandable lecture. We have some questions here. Kadir Abul is asking that, does the air between the bones and disc represents the instability? You have answered it. A question from Ayhan Kanat. There were lumbalization in these patients. Is lumbalization a risk factor for de novo scoliosis?
Yes, I think it can be a risk factor. In fact, I had in these cases, I showed to you at least 2 cases who have also a lumbosacral junctional anomaly. Whether it's a lumbalization or it's a sacralization, it's probably not so important, but yes, it can be an asymmetry in this malformation, and this may lead to an asymmetric degeneration of the discs above. Interestingly enough, it doesn't need to be the adjacent disc. It can be also 1 or 2 or 3 levels above the degeneration. And I still do not understand why it jumps over some levels and sometimes it's directly adjacent. There's still an open question about this.
We have another question from Ömer Ersen. Do you usually prefer instrumentation for type 1? I think for Veriano-Lamartine classification. Then you prefer only decompression?
I think you can, if the major clinical problem is in fact a radicular problem or a claudication problem, I see, and the back pain is not relevant. The patient is not really suffering from back pain. You can do a decompression in this part because it's not in the apex. In the apex, I would say don't do decompressions. I have done that in my younger ages, some 40 years ago when I started, you know, and I have been punished every time when I did that. So in the apex, don't do decompressions alone. You don't need to do correction, but at least fix the segment. However, when it is not in the apex, I think you can do in the type 1, you can do a decompression alone.
Kemal Yücesoy is thanking to you for this nice presentation, and he is asking that, are decompression and stabilization enough in elderly patients? Is correction really needed? I think I've answered some part of this question, but if you have something to say.
Yeah, I think we are always tempted, you know, in elderly patients with high risks and multimorbid patients to do just a decompression or as minimal as possible fixation. But also here, there is nothing which goes around the fact that if you are not adjusting a proper sagittal alignment, you will be punished. You can do whatever you want. The patient will develop almost for sure either a proximal or a distal truncal kyphosis. So you have to consider in your whole assessment, what is the sagittal alignment? When you start to do fixations more than one level, that means 2 levels and more in the context of these deformities, you have to look at the sagittal alignment.
Aebi, thank you. Baran has asked a question. We have seen in most of your cases the traction films. He is asking, do you use traction preoperative in axial stability when you correct the deformity? Let's say it, when you use traction films, or let's start from the basic. How do you get the traction films?
Yes, you know, I do the traction films myself. I go myself in the radiology department and I take the patient in the axilla, and I have one of my assistant taking the feet, and we pull, and when we pull, I say shoot when I think we have the maximum pull, and then the radiology technician, he or she shoots. So that's a very simple one, but it takes me. You know, when I tell them in radiology do that, then these are very poor traction films. When I do it myself, then I get what I want. But there are patients where you cannot really do these traction films. It may also be very painful, specifically when they have kyphosis. Then you can still do that when before the surgery. You can explain to the patient that you will do traction once they are asleep, and then you may change the procedure depending on this traction film. So in anesthesia, in narcosis, you can do obviously better traction and better alignment than when you have the patient awake. It may also happen that you do this separately from the surgery when it is a difficult decision to take. But I would say at least 70 to 80% of the patients where we do traction films, and we do almost in all deformities, also of course in idiopathic scoliosis, we do traction films. You can do it as I just explained to you. I do it myself with a radiology technician.
And I have learned it again from you. It's again a basic question, but can you tell us how do you get the flexion, extension, lateral bending films, also the lateral bending films? Because the answer will surprise most of our colleagues.
Yes, I do the lateral bending films again. I do it myself. I go with my knee on the X-ray table. The patient is in prone position, in supine position, and I take the hip with the right hand, and I take the shoulder with the left hand when I do the right side bending. That means I put my knee in between the rib cage and the pelvis, and I basically bend them over my knee. Sometimes they complain about pain, but that's just 2-3 seconds. And then I do the same thing on the other side. That gives you beautiful bending films. The bending films need to be done in supine position. Bending films in standing is useless because you have the load on the spine. So you don't want to have the spine under load when you do the bending films. You want to have no load at all on the spine. So you just manipulate the spine in the bending.
Thank you, Aebi. Another question from Bülent Düz. Is there any relationship between adult degeneration with Parkinson's disease? It's another topic, but if you want to say something about it.
Yes, this is a very good point you raise. This is a very complex combination, obviously. The Parkinson's disease is basically helping to develop de novo scoliosis, because in the Parkinson's disease, you have asymmetric innervation and asymmetric tonus of the musculature. And this leads to deformities when you have degenerated discs. And therefore, the combination of Parkinson's disease with sometimes very severe frontal as well as sagittal deformities is quite a usual problem. I have a whole series of patients operated with Parkinson's disease and deformities. I didn't talk about that today because this is basically a separate issue, but this is a major problem. And of course, there are also specific demands of these patients, also specific complications of these patients. But there is a very close correlation between de novo scoliosis, degenerative scoliosis, and Parkinson's disease.
Aebi, Tuna Pehlivanoğlu, great talker, Professor. Vielen herzlichen Dank.
Herzlichen Dank.
He is my master. He is asking you your opinions about dynamic and semi-rigid stabilization for the prevention of PJK.
This is not scientifically supported, what I tell you. I believe that until today, there is no really stringent proof that with changing the rigidity at the end, specifically at the proximal end of the fixation, maybe with semi-dynamic rods or with sublaminar bandings instead of screws or whatever. We have done everything. I can give you a lecture just about the proximal junctional kyphosis, and I can show you that we have used every combination semi-rigid, combination with sublaminar banding, combination with prophylactic of the fractures of the adjacent vertebra with, as I showed in one case, with kyphoplasty. Until now, I have not seen anything where you can say that's the solution. With all these techniques, we have seen complications in the sense of adjacent segment problems. So I'm still not clear what is the good solution for that.
Aebi, they want you to stop your sharing so that we can see you in a bigger screen.
Can
you stop your...
I try my best now, but where is this? Now I have no green. Let me see what I can do. I should have somewhere unshare. You said screen share. Wait, no. Pause, share. Stop.
While you're doing that, I'm asking the other question. Tuna Pehlivanoğlu is asking again. Do you apply gap score in your regular basis? What do you think about it, about the gap score? Do you use it when it's useful in your daily practice?
No, it's useless. This is too complicated. It does not, it's, from the theoretical point of view, it's an interesting concept. And I think the guys who have developed that, they did a lot of thinking, but it is partially far away from the practical problems, So I stopped it, and I have been at Rush University 2 years ago where we had, I gave a guest lecture about these things, and we had a big discussion and case presentations, and the opinion of this of the staff people there were finally the same like mine. It's not very helpful in the daily practice. It's theoretically quite a contribution, but it doesn't really work 100%, So I don't use that in my practice. I still try to do this.
No, we can see you now. It's fine.
It's okay now?
That's fine. And
Okay.
Serdar Kabataş is asking that, do you have any essential points for this kind of surgeries in osteoporotic patients?
Sorry, I didn't understand. Can you repeat?
Essential points for this kind of surgeries in osteoporotic patients.
Mm-hmm.
Again, a huge topic, but can you make a little summary for us for the osteoporotic patients?
Yeah, in osteoporotic patients, we use, for instance, screws with cementation. That means we have cannulated screws where we can inject cement through the screws. So it is helpful when you can create we have special screws where we have some openings at the end, at the tip of the screw. So when you inject the cement, you create like a cloud. So it doesn't go in the whole vertebral body. It's like a cloud in the front and just under the end plate, the superior end plate, that's where you have the best bone. So that's one way we can enhance the screw fixation in the osteoporotic vertebral body. There is a big problem, for instance, also in the lumbosacral fixation when you want to do fixation to the pelvis. What we try very often in these porotic patients is to put screws in we start at the sacral pedicle and we go up with the screws through the end plate of S1 and L5, because very often in this degenerative disease, these end plates are very sclerotic. And so the screws are holding there. So that's another technique you can use. And even in the iliac screws, we use a combination with cement. And then what we also do is we do not fix every vertebra with a screw on cement. So we do every second one, and in between we use sublaminar bands, you know, to basically make the whole fixation less rigid. Whether that's really helping or not, I don't know. In some cases, yes, it helps. In some cases, we have seen that even these bands are pulling out through the lamina, which is very unusual because the lamina is the strongest part of the vertebral body. That is, you know, when you take the Luca technique, I don't know whether the younger colleagues, they even know what the Luca technique is, with the sublaminar wiring. It has always been said that this is the last resort for difficult osteoporotic things, because the lamina is cortical bone and it holds. But we have seen cases where even these bands, which are about 5 millimeters large, they have pulled through the lamina. So I have no perfect solution for that. You have to adapt that to the individual case.
Again, from Bursa, Kudret Ben is asking that most of these elderly patients are stable. And do you think that only decompression is enough for that patients?
Yes, that's what I hear all the time. But the reality in my clinic is, you know, I see out of 10 patients, I see about 6 patients who have been operated before. They were all stable and they come because they are unstable, you know. As I try to show you with distraction films, even in very degenerated spines, you think this is stable. There are osteophytes, there is osteochondrosis and all this, where you think this is stable, this is fixed. And suddenly when you do this decompression, the curve is progressing and the whole thing is actually unstable. So we have to be very careful what we declare as stable and unstable. I think you really need to evaluate before you do the surgery whether you can demonstrate a real stability. I showed you a case, if you remember, where we did a very short fixation in a 84-year-old lady because her also the levels below, they were included in the scoliosis, but they were spontaneously fused. So yes, there you don't need to stabilize that. But I try to show with these examples that you have to analyze in each case whether this is really the case, whether you have stability or you have a potential instability. When you say elderly people, they are stable, this is not true. There are elderly patients who are not stable, and you will see the result when you have operated them. You have to analyze that before. But of course, I agree that whenever possible, you don't want to stabilize these elderly people.
We have finished our question. Aebi, I have a comment and a question to you. You're talking about the sagittal alignment and you're talking about the sagittal balance. We know as, in quotation marks, alignment is static and balance is dynamic. But is really sagittal balance dynamic? I mean, you're getting the X-rays, the scoliosis graphs at lateral position, while the patient is getting the compensatory mechanisms. When the patient starts to walk, the compensatory mechanism dissolves. So, I mean, the sagittal balance is not really the dynamic films. If we have the chance, and we see some papers, when the patients are walking, if we have the chance to measure them while they're walking. So
I agree 100% with you. You know, we talk about the sagittal alignment when we say this is static because this is the X-ray, but then we talk about the same X-ray and say this is sagittally balanced. It is also static. The only way you can really analyze that is when you analyze the gait. And today there are more and more research results coming about the gait laboratories in these specific patients. And I think this is a very good, what shall I say, an adjunct evaluation to understand whether the patient is able, when he or she is walking, to balance the spine. So this is a dynamic issue, but in an X-ray, you can never talk and say this is a balanced spine. This is basically a dynamic issue. When you observe the patient, you can do that clinically, but of course, you want to have it as objectively as possible, and then you need a gait laboratory. You know, Lieberman in Houston, he has now quite a series of these patients done with gait laboratory, and it's very interesting the results what he showed. You know, this shows exactly what you say, that the balance, the sagittal balance, is a dynamic issue and is changing when you walk.
another topic that you have talked about, the functional imbalance of the spine. It's related with the pain and with the sagittal balance. The question is that if the patient has a disc disease or a lumbar spinal stenosis, for a compensatory to decrease the pain, the patient tries to bend forwards. The main question is that what is the exact time? So let's say call it as acute sagittal imbalance. When there is no limitation, there is no line there, according to the pain, because the patient is saying that I was walking very good, but in let's say 1 month ago, my pains has started. So my balance is now, I'm standing in this position now. So there is a area that we cannot explain about the time arrival.
Mm-hmm.
So if we can solve the time, if we say it, is it a functional or is it really a sagittal balance?
No, this is functional. You know, I wrote a paper about, I think about 2 or 3 years ago in the European, it's published in the European Spine Journal, about the functional sagittal malalignment. This is, you can have, you know, I showed a case in this presentation where you had a very poor sagittal alignment or balance when you want, and after the patient has been decompressed, he was completely normal without changing anything with one level surgery. So there is a functional sagittal alignment pathology which is due. You can have specifically in younger patients who have, for instance, big disc herniations, they can have a terrible sagittal as well frontal alignment, and you take the disc out and within 2 weeks they are perfect. The same is in tumors, specifically in children. They can have very bad alignments in the X-ray, and once the problem is resolved, you take the tumor out, the patients will realign spontaneously. So there is the term of a functional malalignment, which goes back when you take out the focal compression or the focal irritation.
Aebi, thank you for this really great presentation. Alaaddin, senin sorun var mı?
Thank you very much for this excellent presentation. Başka söyleyecek bir şeyim yok.
Aebi, really thank you for this 2-hour great presentation. When I look at the participants, we had approximately 100 participants here. And I again congratulate Dr. Hasan Kamil and his team. It was really a good meeting. So I think we have to stop here.
Okay.
Thank you so much, Aebi.
I thank you. I thank for giving me the opportunity and for listening, everybody. And hope we will have another opportunity to talk. Thank you very much.
Thank you.
Thank you so
Bye bye.
much.
Atacan kapatabiliriz.
İyi akşamlar hocam.
İyi akşamlar. Good night.